All right, well, we're going to go ahead and get started. Hi, everybody. This is Nick Ferreros, Director of Communications at COA. We want to thank you for joining us for the What is the OCM 2.0 webinar, where we talk about our OCM 2.0 model and proposal. A few housekeeping notes. All attendee lines are currently muted, so you will not be able to talk to us. Following this call, a recording of it and the slides will be shared with all registered attendees. A full copy of our OCM 2.0 application can be found on the COA website on the homepage. If you have any questions after the webinar or want to follow up, you can email us at info@coacancer.org, and we will get back to you as soon as possible. Now I'd like to hand the stage over to Ted Okon, Executive Director of COA, to talk a little bit about what the OCM 2.0 is and why we did this.
Thanks, Nick. I think everybody realizes, and if you don't, let me say it and excuse what may sound like specialty ego talking, but community oncology has really led the way in terms of payment reform, more than any other specialty, and certainly more than any other subspecialty. If you look at it, it goes back with a number of different commercial models. There have been now a couple of different Medicare models, the current one being the OCM 1.0. And I can tell you that COA has been involved in payment reform, starting with the oncology medical home, really about 9 years or so. In fact, I may have lost time, and it may be 10 years that we've been involved in this. So we are pushing this along, and we are fully committed to the OCM 1.0. We think that in general, there's still room for improvement in terms of starting with the patient experience, the quality of care, and certainly the amount that we spend on cancer care, both from a system-wide payer standpoint as well as the patient standpoint. So, we have a long history here. As I said, we are totally committed to the OCM 1.0, trying to make that successful. We had a team meeting with the CMMI OCM team the other day in Baltimore, and we reiterated our commitment. We did hand the team a number of different fixes that we think that they have to make, and we're communicating back with them. We did send Adam Bowler, the head of CMMI, who will be departing, by the way. We did send him a letter that is available. It's up on our website, but we will be sharing, especially with the OCM participants, 80% that we have networked in a cooperative network, our follow-up to this meeting. And we spent all day yesterday, our OCM team, an OCM 2.0 team, and that includes all the people that you have on this, Nick and Bo and Fred, Dr. Snell, but also Dr. Diaz, who's the president of COA, Dr. Gould, who is the immediate past president of COA, and now immediate past co-chair of our Oncology Payment Reform Committee, our two new co-chairs, Drs. Kesha Patel, Leyland Wolfong, just tremendous new co-chairs, as well as our outside consultants, Kavita Patel, Basit Chaudhry, his team, and I'm probably forgetting some people. So we have a large team that's involved with looking at this. A lot of people say, why are you doing the OCM 2.0? Well, we believe in the basic model of the OCM 1.0, but like everything, whether it's a piece of software or a piece of hardware, it needs to evolve, and it's time for 2.0. And so 2.0 is basically our version of the OCM 1.0 added onto. Whether you read our PTAC application, I know Bo will touch upon this when I hand it over to him in 2 minutes, but basically you may ask, well, wait a minute, there's no kind of real, where's some of the details about the model? All the details are in the 1.0. So we're actually taking the 1.0, making some changes, and then some significant things, and especially including the drug component, the value-based drug component that you'll hear about, in the 2.0. So that's a big deal. Everybody wants to know about drugs. Everybody wants to talk about drugs. But as I say, and I think a lot of you probably heard me say before, if we're going to get paid as providers based on the value of services provided, the same thing should happen on the drug side. So when you think of this OCM 2.0, this is a big initiative. We want to basically create the universal payment model. As you will hear at the end of this presentation, we're doing a lot of work with payers and even payer groups. There are a couple things that we can't talk about, but you will hear by our payer summit at the end of October, where we'll be unveiling some really bold, big initiatives. We believe that there should be a universal payment model for cancer care, whether it's Medicare, private pay, insurers, whatever the case may be, that can be modified and work between the provider and the payer. So this is a big deal. A lot of people say, well, why'd you go to a PTAC application? Why'd you file this? We did it for a couple of reasons. Number one, PTAC gives you amazing feedback. We're not necessarily counting on the fact that PTAC would even approve this, or if approved, HHS would implement it. PTAC has approved a couple models that HHS has not implemented, but we wanted, it has been a discipline for us to go through the process. We got a lot of feedback. We've been able to engage some companies. In fact, if you look at the PTAC application, there are companies that have actually put their name on our PTAC application, pharma companies, and that's pretty amazing. Because I've worked for 2 pharma companies, and you got all kind of legal issues and battles and stuff like that, and it shows you, I think, some commitment to some of the companies in terms of really advancing value-based payment. So that's a big deal. And the other thing is, it's now allowed us to talk to a much broader audience of payers, as I said, employers, groups on health, in terms of a broader model. So we are committed. When you think COA, we are committed to payment reform. When you think oncology, community oncology in general, talk is cheap, but community oncology has implemented more models than you can possibly imagine. And as you know, our payer summit's coming up at the end of October. Plug for that. And both that and at our conference, we spent a lot of time talking about payment models. So this is a big deal, big commitment for us. You're going to see a lot more exciting things. And with that, I'm going to hand it over to Bo. Bo, it's all yours.
Good afternoon, everyone. Thanks for joining us today. Thanks, Nick. Thanks, Ted. Okay, Nick?
You've got control, Bo.
Very good. Okay, super. Thanks for having us today, and we hope that you can walk away with some great stuff. If you had only time or the memory banks for one picture, this is a good one. This is the one single perspective of what the OCM 2.0 is all about. It is a blueprint for everyone, including Medicare. Of course, PTAC is specific to Medicare, but we want it to be about everyone, including commercial insurance companies, employers. There are many components within the clinical standards, with including accreditation measures. We were going to talk about payment model itself. And as Ted says, there is a very specific focus on drugs. Drugs has proven to be the hardest thing to manage and predict in all models. And we're trying to tackle this head up and just to the point. Also, there's a very, very strong emphasis on transparency, collaboration, flexibility, efficiency, and open lines of communications. And we're going to get into that why and why we're finding that to be so fundamental to successful reform. So this is one good snapshot of what our afternoon is going to be about, and we're going to some background. We're going to spend a few moments talking about the background. As you know, if anybody who was involved in the first 400 letters of intent and want to participate, the OCM model was started July 1st, 2016. We were involved or engaged probably in 2015 as it began to unfold. There's 10 6-month episode periods. There is a practice transformation process that was it was almost traumatic in some cases, but it has been very good. There was a clinical registry that's still an issue. There is incentive payments and shared savings programs. Incentive payments is, okay, we want you to use this money to finance the transformation. And then here's some shared savings if you do well. Started out with 195 teams. We're now at 176. At one time, it dropped down to about 170. And then it dropped up and went up to 176. I'm like, we asked the CMMI team, we didn't realize you guys were accepting new participants. Well, come to find out, the growth has been in acquisitions of OCM practices acquiring non-OCM practices that then became OCM participating practices. So that has attributed to the growth. There one time were 17 commercial insurance companies involved, and the criteria was very simple. I think they needed to have measures, and they needed to have basically the criteria was very simple. Measures, I think, and even shared savings. And then beyond that, they could do whatever they wanted to do. That's now at 11, as we understand. We also have been told or understand that this represents about 30% of all Medicare beneficiaries who have cancer. However, if you look closely, over half of that 30% is represented by only 5 different cancer care teams. These 5 cancer care teams are watched very carefully, saying, okay, what are you doing now? What are you going to do in the future? Because they are leading some of these efforts. So the OCM, or as we know it, or what really is OCM 1.0, has been very fundamental to these changes. We've also been watching or observing and listing 20 total 20 models. All of them are very different. There are some similarities with shared savings. There's some similarities with measures, but for the most part, they're all different. Interestingly, there are 7 different reform models in the state of Florida alone. Can you imagine the management difficulties managing these 7 different models and trying to understand, and particularly if one patient goes from one plan to another plan and how that is emphasized. Some of the examples and some of our heroes of the past, Priority Health is probably one of the first commercial models to do a reform in cancer care. This goes back probably 8 years ago. There are some national models. Aetna, Cigna, Humana has recently announced. United Healthcare has done some, they were one of the first. Many versions of the Blue Cross plans, there are again some similarities, and they've tried to do some templates to help the Blue Cross models. We're also watching 2 employer-based models that have just taken off, and they are rewriting or redefining the whole cancer care delivery process with the focus on the patient. Those have been very interesting to watch, and we will talk a little bit more about that further in the discussion, and also Dr. Schnell is going to mention that later on. I want to put a plug in here, and because I think it's anecdotal information about the history of COA's involvement in reform. Oh, it's been 6-7 years ago, Dr. Ted O'Connor and I went to visit Dr. John Fox up at Priority Health in Michigan, one of the first models. And it was revolutionary. Nothing had been done like this on the commercial side by anyone before. And we were like, ooh, and ah, and saying, this is great stuff, and this is pretty awesome. And we were very impressed. But we asked Dr. Fox, I said, Dr. Fox, how's it going? Now, keep in mind, we had Dr. Fox in the room and some of his team, and also some members from a local cancer care team. They're very active in the model. They were in the room, and then ourselves. We were there to learn and listen. We asked Dr. Fox, how's it going? His response was, you need to ask them. And like, that sounds so simple, but that concept of making sure that there's agreement on the goals and the purpose and the success of a model, that was a very historic moment in regards to reform. And we've seen more of that as we've looked at other reform models. But that was, we remember that very clearly. I remember the words spoken and where they were spoken. More background. Many of you guys on the call are involved in our OCM Support Network. It is a peer-to-peer support network representing about 80% of the OCM participants. It's designed to spotlight those that are doing things well and for them to share where they've struggled. It's a private or closed listserv or communication network, so they can talk to each other. Says, what about this? What about that? That's also been used to help design, organize, design, and submit letters to CMMI with specific instructions and feedback. Also has helped guide discussions with them one-on-one. And it's also help us design this whole PTAC application process. Listening and learning and observing all the things that are happening there. We've also done 5, I guess it's actually been more than that because we had some side meetings, but 5 2-day meetings, which we call the Payer Exchange Summits. If you've watched the agenda items from then till now, they're very, very different. And it reflects the maturing of this whole reform concept in cancer care. And for those of you who've been around a while, healthcare has not changed much in, say, 45, 50 years. It's changing dramatically now. And you're seeing this happen as we try to do on these Payer Exchange Summits, just learning from successes. These are not your typical lectures or presentations. The majority are panel discussions of real players doing real things to make the world better in cancer care. This year's focus is going to be on the employer. The reason for that is the employers seem to be the main driver of effective, meaningful, and lasting change quickly. And as Ted mentioned earlier, they're becoming more educated through the process. They're realizing they have choices, and they're getting very creative. And we want to bring them to the table, sharing the discussion, learn from each other, and try to make that process better. We've had CMMI in attendance in most of these meetings, and they've been very, very effective. If you've not registered, you actually will likely get an invitation. It's by invitation only. Let us know if you're interested. Keep in mind there is a requirement. If you're a provider, you've got to bring another stakeholder. And if you're an employer, we're asking you to bring a provider. The whole notion is to learn from each other. It is a great time to learn from each other by asking questions and taking notes. And Dr. Schnell is going to speak about the growth in the employer area and why it's becoming more and more important. PTAC. For those of you that are not familiar with PTAC, it is the Physician-Focused Payment Model Technical Advisory Committee, or PTAC for short. It was started in 2015. And its hope and its goal is to say, you guys tell us what can work. Give us your ideas for model. There are at least 34 proposals out there, three of which for cancer care. And as Ted mentioned, CMS is yet to implement any PTAC idea. However, they are they're a vehicle to for them to receive. It's also a great vehicle to get good feedback, but they are a very, renowned committee of physicians and non-physicians who make decisions. Some of them are very specific, some of them very general. Ours is out there. We hope to be having a meeting with them later this year about our particular model. They are the ones that's the funnel to submit all great ideas. And a lot of effort's been put into our effort to put it out there for them to review. So what is ours specifically? What is going on in our PTAC application? If you've read any model application, ours is not typical. And there's reasons for that. You look at the history of COA, we've been around there almost 20 years. Our mission has been about trying to do good things for cancer care with the patient in mind. And we've tried to keep the same thesis in this model, in this application. It wasn't always that way, but we're focusing on the global appeal to reform for the betterment of the patient and for all. So within our PTAC application, you will not find your typical spreadsheets and models, numerators, denominators, and calculations, and etc. But what you will find is a lot of history that has gotten to this point and what we've learned from history, and also guidance on the calculations and the modeling to make things effective. So it's been a good document, and we're going to get into the detail right now. It's a simple view, a simple illustration of what reform or what healthcare should be about. It should always be about the patient, always. Now, and you can think in terms of the three-legged stool. It makes sense, but if you look at it in a different way, there are three legs holding the patient up. And if any leg failed, then it's not good, then it's not best for the patient. High quality cancer care, meaning standards. What are the standards for high quality cancer care? Not standards that were for something else, but for cancer care. What is that? And how can you tell if high quality cancer care has been delivered? How is it measured? What are you, how can you tell if it's good? How is it different than your peers? Whatever. What about the value proposition in that? And then if you take this, okay, I'm delivering the care. There's proof that I've delivered the care well. Now, what is the reward, or how can I be recognized for doing it well? And how can I be recognized I'm doing better than my peers? And that's the payment methodology. Traditionally, historically, you're paid for what you do, whether you do it right or not. And this whole notion, this whole emphasis of reform is like we need to get away from the concept of just getting paid just because we do it. We need to do it because we're doing it well, or adding higher quality or high value along the way. So that is the three-legged, or the three components of any reform model, particularly our model. And we're going to get talking to the details of what ours is specifically. There's a reason that this is the first screen or emphasis of a model. You're like, well, Bo, this is simple management. You're absolutely right. However, if you look at a lot of the models out there, they are complicated. They're oftentimes not transparent. There are obstacles that present, or issues that present real challenges. So the emphasis here is for any reform model, particularly any reform model for cancer care, particularly, it needs to be designed, and this is very, very important. It needs to be designed so that it represents the same efficiency and effectiveness that is being asked of the participants. I'm like, well, of course. However, if you look at some models, they are not efficient and they're not as effective as they could be. So we're saying keep these things first and foremost in the reform efforts that you're doing, whether you're in one already or you're looking at one. Make sure there's collaboration, communication, timeliness, transparency, and the incentives are proper and everybody agrees upon it. Let me give you another example. This notion of a huddle of cancer care teams became very prevalent in the OCM. And they're very good, and it's helped add some efficiencies and some clarity of taking care of the patient. But if you think how these words also apply to huddles, that's exactly what needs to happen on a reform model, even more so, because you're working in uncharted territory. But this is key to our model in all areas, and that is to work together to make them better in communication. It sounds simple, but it's often overlooked in many models. What are our goals? The emphasis is always on the patient, as in our model. That is first and foremost. If it's best for the patient, then we must do it. There's the universal concepts of the high quality cancer care and the universal concepts to measure the quality care, and direct focus on drugs and therapies and their role to promote quality and value. That is probably the most difficult, and for many reasons. As of, was it yesterday that we saw where they had removed the issue with the proposal to eliminate rebates to Medicare Part D and Medicaid managed care program. I'm like, which we've been fighting for a long time. We've also heard horror stories about rebates and discounts that drug companies are paying to get their product in front of the patient. And that's before the product even gets there. And all this is being done outside or without involvement of the patient or the provider. There are all kinds of complications that have worsened the whole delivery system because the incentives are not aligned properly. It is not easy. It is complicated. There's many obstacles along the way, but we're saying, hey, let's address them heads up. As Ted mentioned, we have 6 drug companies listed in our PTAC application. It was not easy getting them to agree. The agreement is that we're putting a sort of our gauntlet out there saying, hey guys, you want value? Let's let it happen. Let's give them waivers to their satisfaction that allow some value-based arrangements between the drug company and the provider team, and extra points if it's with the patient, no longer with the payer. And we think that can be very key. Now, we're often asked, well, what's in it for COA? We simply want the best thing to happen, the right thing to happen. That means that if we're here to help. If a drug company would like assistance to recruit some providers, we will be glad to do so. From our listening and conversations with them, this is not always easy. And sometimes folks are in agreement until you get down into the details and they're not capable. So a lot of this is grooming people to get ready for it. Now, if you have other drug companies out there who are listening today, we encourage you. Yeah, join up, support them. The more the merrier. Even though there's 6 people listed in the application, we are hopeful that there will be many, many more when we sit down with the PTAC committee and says, here's a whole team. We're ready. However, we need waivers to make it happen. But hitting the drug companies directly, hitting the drug issue directly, and with the cooperation and the drug companies at the table to do something on value, we think it's very, very key. Collaborative partnerships, collaborative keyword for payment methodology, whether at the federal level, regional level, or the employer level, do it collaboratively. Do the things that make sense. We've talked to many that have had discussions with different payers or employers, and the first thing that has to happen is you have to learn to talk to each other because you're speaking 2 different languages. What appeals to one may not appeal to the other. So you've got to find that common ground to do things together on the payment methodology side. Those are our goals. Emphasis on the patient, always universal cancer care that's high quality, quality measures that prove it, focus on the drugs, very, very, very key, direct focus on the drugs, and then collaboration. So those are our focus. Now let's get into more detail. Within the quality cancer side, we are pleased to announce that we have been working with ASCO for the recreation and modification implementation of the oncology medical home that Ted mentioned. There's many, the more we do this, the more excited we become at it because there's many efficiencies that happen through this process. The framework that was established with their COPI program, which was the Quality Oncology Patient Initiative, I think, and their quality clinical data repository processes, already set the framework for the promotion of quality care, but the efficiency of gathering the quality data is already there. So that is happening very quickly, and we are hoping to announce a live date later this year. Within that, there are 6 standards. If you're one of the 10 initial pilots, 5 of those look familiar. The 6th one has been added, and that's chemotherapy safety. That comes from ASCO's rich background in that area. But those are the standards, and within those standards, there are criteria or expectations of what needs to be met in that. That information is out there already. You can begin working on it. And if you look at the reform models that are out there, whether it be commercial or Medicare or whatever, this is all consistent with what it was at that time. The measure reporting will be through this process that's out there, but it will be with greater efficiency, go to a common database. Now, what are those measures? Very short list for now, which is good. They're listed here. Now, I'll also emphasize here, and this is a very key point, the accreditation will include an on-site visit. That is consistent with COPE participation in the past. It's also consistent with our prior oncology medical home efforts. And it also means that there will be compliance reporting required through the years for the accreditation, saying, okay, you said you're going to do this. How show us that you did it? Here are the measures that we have so far. Others will be determined once the steering group has been completed. That will include multiple stakeholders to say, okay, this is what we have so far. We're also trying to align as best we can with the updated list of measures with the OCM. And the OCM has been very effective and very transforming care. It's been great. And that's one reason why we kept the title, is because in honor recognition of work that is done. So moving those things forward. The efficiency comes that most EMR systems are already capable and are able to report some of these numerators and denominators electronically already. So it's there. That removes some of the administrative overhead required to gather and report these data. Also, you have the benchmarking available of how you're doing, and that would be available for all models. Now, how the measures are to be used, they can be used in many different ways, and that's up to you and what is how you negotiate or implement those measures. That could be used for threshold qualifications, meaning they have to meet X measures before something happens, or it could qualify you for something, meaning just like the OCM, it sort of becomes a multiplier for any shared savings that you may have. That can be determined, but the measures would be there already for you to use in the base. We mentioned the drugs and therapies. This is this is big. The waivers would have to come from them. It needs to be to their satisfaction. And the arrangements would be with providers and possibly patients. The provider care teams need to be prepared to participate. If you come, hopefully, come to our payer summit, we will get an idea of what some of these value-based arrangements may look like. We have some of these teams that will be in the application, our listed applications. Okay, you tell us, what does this mean? And what will a provider need to do to get ready for that? We want there to be numerous pilots. Just if you look at many different reform models, there probably is no single size fits all for a value-based arrangement of drug. So let's see what can happen out there. We've asked them to keep us in the loop once they implement something, so we can learn from what's working, not working. We have no other ask other than that, and to help them make it happen. Drugs would be included in the total cost of care, and we will also look at target therapy and biosimilars. Now, if you watch the news carefully over the last, actually watching the OCM and even recently, there has been some, I guess, pressures put on care teams to do a drug versus another drug because the payer's recommending it, and maybe not be in the best interest of the patient. Those types of things need to be addressed in this addressing the drug issues for the OCM. Now, payment methodology. Well, Bo, what about all the details? We do not go into the calculations that are in most PTAC applications. If you're interested in those PTAC applications, we can load you up with all the letters and documents that we've shared with CMMI that addresses those calculations. However, we are trying to focus on a universal appeal for methodology reform, and therefore are keeping our points at this level. We want it to be universal for all payers. Certainly Medicare is tops on the list, but for all payers. We are also recommending that registration into the model could also double or facilitate or ease the whole attribution issue and include the pre-certification model for commercial payers, so therefore there's more efficiency. We're also asking that all clinical trial patients be included. Those that are heavily involved in clinical trials review it as state-of-the-art medicine and see that that is very critical to improving quality and value. Therefore, why not include them? We'd like the benchmarks for savings to be transparent. If we can figure out a way, let's let that goal be known before you get into the episode period or the measurement period, so you know what you're after. We would also like shared savings to occur, total cost of care. But if you are in a commercial model, how about shared savings be between provider, payer, and employer? What a novel idea. Let all three work together for the shared savings component. Total cost of care to be included until death or 30 days beyond last treatment. Some models are excluding hospice, which is like, why is that? And we also would like winterization of 10 highest and lowest cost cases to be thrown out there. Basic risk methodology, as Tim mentioned, we spent most of the day yesterday talking about methodology issues that we see today and how you got issues with exceptions, novel therapy, MEOs and timing and reporting, whatever. All of those things we have a good handle on, but we kept the focus on this application like we want it to be an efficient model that everybody can use. Time reports to participants, one of the other feedback we heard is that it's hard to make decisions when you get feedback a year after the fact. It needs to be timely communications. Now, we also heard today, which is interesting, that I think it's HHS has announced a quality summit to streamline improved quality programs across the government. These new programs were started in 2000. However, and I quote them, the quality programs across agencies as a whole have not been subject to a systematic, objective external review since their inception. I'm like, wow, that's been 19 years. Payment reform needs constant management and improvement, very much like what you're having to do with your own models, having to look at it consistently along the way. So that's the payment methodology piece. Now, other details to be developed. It is unrealistic to expect it's not that simple. You're exactly right, it's not that simple. However, it can be, needs to be more complicated. It can be, should be more complicated, but it needs to be done together. There needs to be full agreement. If you look at the effort that COA and team has spent trying to suggest improvements along the way for even the OCM model, some of these, I guess, intensity of some of these improvements could have been lessened if some of that collaboration would have been done in advance. As we watch some of the other commercial models, some of them get high marks for their communication, which is real time, both in reporting and access to changes and improvements. As we learn in the last, I guess, couple of months, many commercial models are actually on their second or third version of their reform because they're continuing to improve, but they're taking that feedback and improving upon it. So details should be in place. We recommend them. It's very complicated. Cancer care is one of the most complicated diseases there is, but do so together and use the history that we've learned through the process to make it happen. But we absolutely positively won't expect it to be more complicated. I'd like to say a huge thank you to all that have assisted in this process. This has not been an easy task. We have changed strategy numerous times. A couple of times it was somewhat technical, and but it was not a natural fit with COA's heart and their mission. So we kept the end product we're very pleased with because it reflects COA's personality and our goal, and that is cancer care better for everybody. And let's work together to make it happen. There were 50 plus discussions that helped us along this effort. Many of them were over, I think a dozen were with long meetings with some leading science companies, drug companies who are doing great things out there as we're trying to figure out this notion of value. And this application, we went through, good gracious, over 60 versions trying to get there. It is available. The comment period from the application is over from the PTAC standpoint. However, we welcome your feedback. If you have a chance to look at the 30-some pages of the application itself and then the 250 pages of attachments that go with it, take a look at it. We welcome it. Things that you like, things you dislike. Even if it's their comment period's over, tell us, because that's how we will make it better. And also, if you have questions, if you want to have sidebar conversations after the fact to get in more detail, you're welcome to do so. And with that, I'm going to turn over to our good friend, Dr. Fred Schnell, who will talk about what we're doing with the employers from this point.
Thank you, Bo. I'll be brief with this. We want to get some time for questions at the end. I'm a former president. I'm a medical oncologist by trade. I worked for almost 35 years in the clinic. Was a previous president of COA for a couple of terms about 12 or 13 years ago, and became the chief medical officer at COA almost a year and a half ago, predominantly to work on the things you've heard about today. So most of last year I spent working with our team, developing some of these programmatic, documents and plans. And beginning at the first of the year, my role has transitioned into, and it's important in this discussion, I think, to employer engagement and empowerment. Particularly the last 3 or 4 months, I've come to learn that employers and employer coalitions are deeply involved in this, and increasingly so, as cancer care costs now represent approximately 16% of employer costs. And with conversion of cancer from an acute illness to a chronic illness, there are many cost-related and value issues that they have increasingly become engaged in. The most receptive groups are the self-employed, self-insured groups, and that is a strong trend in the employer insurance choice environment. And they're seeking collaboration. They're seeking some guidance as to how to deliver quality for their employees and to get them back to work and keep them keep them economically and physically and mentally healthy. Some of the most impactful reform initiatives already have begun as employer-led initiatives, and COA is engaged in a couple of those in a fairly deep way at the moment. The notable one that we are directly sponsoring is the Florida Connections Program in Central Florida that has been up and running since the first of the year, and is likely to be a model for commercial insurance reform and payment methodologies in the future. We don't believe that what we've done and what we've produced that you've just heard about in depth is limited at all to a federal or Medicare-based program. We think almost all of the initiatives that we're talking about with some tweaking would be applicable in an employer and a commercial marketplace, and are exploring that are trying to lay the foundations for exploring that collaboratively with employers across a broad geography and across an expanse of clinical space. We think that employer buy-in in these reform efforts is essential for these to have a a place in the commercial coverage of American citizens, and we believe that COA has resources and can build to making some of these work. I've met with numerous individuals, especially in the last 3 months, representing employers' initiatives, employers' coalitions, and it's amazing what's going on. And it's amazing the interest level both on the COA team side and also on the employer side to collaborate in some of these issues. Our meetings have been terrific. Most of them have been collegial, and again, I've spent a lot of hours trying to build relationships, and we're hoping that we'll be able to segue those relationships into programmatic improvements. At that, I will stop, and I think Nick's going to pick it up and try to address questions.
Thanks, Fred. Thanks, Bo. So a full copy of the PTAC application is on the COA website. We're now going to open the floor to questions. As I mentioned, everyone is on mute, so if you have a question, type it into the Q&A box on your Zoom platform. Every computer is a little different, so just look around for it if you have one. If you are shy, go ahead and email someone at COA or our general box info@coacancer.org, and we're happy to set up individual calls. Bo, we have one question that has already come in. How is the payment different from OCM 1.0?
Hello, Dr. Barbara McEnany, who happens to be the hero and champion of the Come Home program and very key to a lot of this reform effort. Very valid question. I'll answer it in a couple ways. One is, as we've supported and followed the current OCM model, what we're suggesting are improvements to the methodology or payment pieces to clean it up, A to Z. Not only in the risk methodology piece, but the timing for reporting, exclusions, novel therapy, the website, A to Z, but focus on the methodology pieces. We're continue to see issues with exceptions where some diseases are just really skewing the results, and sadly, people are not able to do what they thought they could do. And how they're interpreted, how novel therapy is being read, and the timing of that with regards to the model. We've heard issues on HRR and HCCs and how they're being played out. So from the OCM standpoint, we're saying, hey, let's sit down and talk through some of these things, try to make them better. Now, we've had some meetings with CMMI to help improve that. It was interesting. It was with CMMI staff, and then we had about 8 active OCM participants in the room. And at the time, the contractors, which CMMI uses, were, as you know, Dr. McNair, they're not allowed to sit with providers. However, we think that's an obstacle. So an idea is like, can we have a waiver where providers can sit down with contractors to add efficiencies or clarity to the methodology that they have currently, so that everybody can understand it, and so they can point to certain areas that this is where I did well and why, this is where I'm struggling and why. That's on the Medicare side. They are far more complicated than any other model. On the other side, commercial payers are not equipped for that degree of complexity, so the same thing would apply. Sit down, collaborate on the risk piece. Most commercial models aren't even addressing risk or risk adjustments, but get to where you can work together and grow and mature, get better at it as you go along. But we're suggesting clean up the math on the current OCM model through all of the things that we suggested, and for the commercial model, start where it makes sense today to get started and to approve it, but reach agreement. We talked yesterday, and hopefully no one will throw tomatoes at us, but like, if we did it right, everybody should be in agreement to go into two-sided risk because they understood it and they could point to it and they could see the benefit from it. Who knows what it's going to be like in the 1st of December? But our goal is for everybody to feel much more comfortable. Right now, there's just too many questions about how well they're doing and not doing. And Dr. Rankin, I hope that answers your question. But from the OCM standpoint, we're recommending pretty much, let's start from the bottom. If it took a 2, 3, 4, 5-day event to work through some of this to make it easier and better for everybody, so be it. But we continue the great work, but we want the methodology to be more transparent so people could manage and respond and make it more actionable. I hope that helps. If not, we can talk on the side. More questions?
One more question has just come in. But when are we hoping that CMS would transition to the OCM 2.0? And what barriers or concerns do we expect them to have to the OCM 2.0 proposal?
Good gracious, they might have been sitting in the room on Wednesday. We posed the exact same question to the CMMI staff. Ideally, and we present this to them. Ideally, we said we would like to know what's going to be in their next version of OCM, and we need to know before they have to make a two-sided risk decision. Right now, you're looking at trying to make that decision without knowing what the future may be. With that means then you're getting a prelude to an ask that we'll be making to them. We'll be asking for an extension of the model so these timing issues can be worked out. They are very silent on what their OCM 2.0 would look like. We are hopeful because they now have, they may be on this call, or they have our PTAC application. We hope that they will be receptive to working with you guys and us to clean up the methodology, to define OCM 2.0 from either the operational standpoint, the methodology piece, communications, reporting, whatever it is, to make OCM 2.0 better than it is. And I know that I'm sure a lot of folks, they feel good about it, and that's great. But as you know, we can do better. We can do better, and that's the goal, is to do better and to keep this momentum going on reform. They don't know, and their hands are tied on what they can say and when they can say, but we hope that they will take some of these requests to heart as they get to that point, and their 2.0 will look very close to what we're asking for in our 2.0. Let's clean up some things, and they've tasked us to be very specific on what they need to do so. We will be doing that. If you'll be on our OCM network call later this month, we'll get into some of these requests. I'll say that the two main items that we did request from them on Wednesday, one is we would like to have an extension for two-sided risk, and we needed clarity for what's to be in their next version. After that, we went through a series of, as we mentioned, a series of methodology suggestions, improvements, and issues that are just, they're tripping up folks, and they need to be addressed. I hope that helps.
All right. Next question. How will the OCM 2.0 impact practices that may be considering leaving it due to their inability to decrease expenses to meet the PBP?
It's a very fair question. We did hear from Wednesday that if it's any comfort at all, that when they come out with version 2.0, their next version of OCM, that practices that dropped out or failed to get any performance-based payment, it would not be held against them on the next version. You speak to the heart of really what we're after, and that is that we want everybody to stay in, but they've got to feel good about why they're staying in and understanding why they're achieving performance-based payment and be able to respond accordingly. That's what keeps us up at night. It's like, we've got to make it better, and we've got to make it better for those folks that are struggling to do. I've yet to speak to any OCM participant that can tell me specifically why they achieved a performance-based payment. They have some ideas, but they can't point to the math. And I'm like, that's just not where we need to be. We need to be able to say, this is why, and this is what we need to address. Now, I'll also emphasize that one of the other suggestions we made to them, and in speaking to the administrators, managers out there, You guys need reporting that helps you shape behavior, meaning you need feedback reports that are at the physician level. So you can say, hey, we love you, but here's an issue, or awesome job over here, follow what this guy's doing, so that you can modify or adjust, give attention to behaviors that are just that you're not able to do. Those that are able to do that at the physician level are having to pay big bucks to consultants to help them do it. Like, again, some of those operational issues that need to be addressed.
All right, we have time for one more question, and Bo and Fred, I think this might apply to you as well, Fred. Where does COA feel employers can make the biggest impact to support the OCM 2.0? And I'll take narrator's liberty to also expand that to other reform efforts. Where does COA feel employers can make the biggest impact? And some ideas are benefit design barriers, performance-based payments, cancer screenings, a flexible work environment. What are your thoughts, Bo and Fred?
Fred, you want me to start?
Sure, Bo.
Cool.
Well, actually, let me say one thing. The major synergy we've discovered in the last couple, 3 months, or at least I've discovered in the last couple, 3 months, is a concern that is at the core of a lot of COA's lobbying efforts this year. We want to make costs transparent. We want to establish what quality standards are. And a number of the employers and the employer groups that we're interacting with have a deep interest in things like PBMs and about access to quality care at a very core level. So I think those are the biggest opportunities for synergy moving forward.
I'll add to what Fred says. One thing that we are hearing more and more, and it seems to be, there you go. Typically, when it comes time for employment year, the payer or the benefits consultant says, okay, it's time to re-up. Here are your 5 choices. And you have to do the math to figure out, okay, who can afford what about a premium increase, whatever. And you have to make a choice based off what they give you. We are seeing, due to their education, absorbing and understanding some of the complexities. I don't know if Dr. Schnell mentioned the RAND report came out recently, and it exposed the cost difference in cost shifting that's happening between Medicare and other payers, and they're riled up. I'm like, good gracious, but cost shifting's been going on since 1980, but they're just now figuring it out. So the employers are becoming more educated. So the best advice to employers is that, you can do better than that. I have some ideas. As they start to understand cost differentials between side-by-side of care or access to their oral drugs, whatever, get creative in their own plan design. And I'm not telling them what to do, but saying that there are options out there that says, I'll look for another carrier that can give me options that fit. My advice, though, is keep in mind that employers typically, most employers, all that we've talked to, they have a whole different need set than what you typically see from a provider. Their need is mostly about their employees' experience, period. How can that be improved? Sometimes that's back to work. Sometimes it's accessibility. So sometimes it's cost, but that's a whole different vocabulary. Get to know them, get to know what their needs are, and help them do so. You'll hear more about some ideas of that if you come to our summit, but that's where it can be fun, getting to know each other. One of the successes that happened in Florida is how some simple conversations with some employee survivors asking a question about their cancer care journey led to that model. It was that simple. Tell me about your journey, and the things that they learned that we don't even think about. And now they're getting addressed and to improve the employees, the patient experience. So start with education, understand their needs are, let the employer know they have choices, help them figure out where they can apply those choices.
And I'll add to Bo's answer. If you are an employer coalition, or have any contacts with them and are interested in this topic just generally or very specifically, please feel free to reach out to us. We'd be happy to have conversations, even if it's just to begin the dialogue and begin, some basic education, or even do more in depth. We have members across the country that are interested in specific reform work, so it would be great. We have one last question, and then I know we're over time. And Bo, this may be impossible for you to answer, but we'll throw it out there anyway. How confident are we on meeting PTAC standards for approval?
PTAC. Oh, that's a good fair question. Who knows? We didn't go into this expecting them to give us a big hug and say thank you for making the world better. We did not go into it that way. However, we hope we get their blessing, which is that we'd like that. If not, our mission continues, because everybody else, Medicare's less than 50%. The others, that's a bigger task. So our mission continues. We hope that we get at least a blessing and to say thank you, move forward. And if we do, we will. And if we don't, we will move forward on that also. But we hope they do. And part of our education or communication, everybody else, is one of the goals is to emphasize the universal appeal for meaningful, transparent reform for all, not just Medicare. So that's the message. So if you like some of what you heard today and you agree with it, let us know. When we show up on the PTAC team, we'll say, here it is. We'll be like, what is it, Miracle on 34th Street? We'll have these bags of here's letters of support or, suggestions. Because we want the PTAC committee to know that we all want reform, but we want it to be meaningful. We want it to be lasting. We want it to be that all can absorb it and implement it so that the patient benefits. That's our goal. That's always been our goal.
All right. Thank you, Bo. Thank you, everyone, for joining us for this webinar. We're sorry we're running a few minutes late, but hopefully you found it informative. A recording of the webinar and the slide deck will be shared with everyone after this webinar concludes, either later this afternoon or first thing on Monday morning. Please feel free to reach out if you have any questions or want to have one-on-one conversations with us. We are happy to make the time, and we look forward to working with you and collaborating to make oncology payment reform a success in the future for patients. Thanks.
Also, add that in the end of the slide deck, there is, for those that are interested and like to do this kind of thing, there is a table that compares current OCM to what's in OCM 2.0 at the item level. It's in the deck. We didn't go over it today just for the sake of time, but it's there for your reference. So thank you, Nick.
Thank you all, and have a great weekend.
Thanks, Nick. Thanks all.